But you raise an excellent point about maternal mortality. I mean, Beyoncé had an issue with her births, with her twins.
Yep.
Serena Williams
Yep.
almost died, it seems, from a blood clot. And so, to your point, it doesn't matter whether you won a Grammy, you won a Grand Slam.
Black mothers in America are dying at 3.5 times the rate of white mothers. Behind that statistics are daughters, sisters, friends, neighbors, and women whose lives depend on our collective willingness to confront this crisis. Welcome to Prescribing a Healthier Future. I'm your host, Dr. Akilah Weber Pearson, OB-GYN, California State Senator, and someone who has seen firsthand what it means when the healthcare system fails the mothers it's supposed to protect. Today, we're having an essential conversation about Black maternal health and heart disease, because here's what many people don't realize. Cardiovascular complications are the leading cause of pregnancy-related deaths for Black women. And those deaths don't just happen in the delivery room. More than half occur in the weeks and months after birth, when new mothers are sent home without the follow-up care they desperately need. What makes this even more devastating, more than 80% of those deaths are preventable. Preventable. That means with earlier intervention, better provider education, and stronger support systems, we could save the lives of mothers who are dying right now. This isn't a niche health issue affecting a small population. This is a public health emergency with roots in systemic inequalities that touch every community in America. My guest today is Courtney Christian. Courtney serves as Deputy Vice President of Policy and Research at Pharma, where she focuses on health insurance reform, prescription drug coverage and public health programs, and health equity. But before that, she was on the front lines of this fight, serving as the Director of Policy and Advocacy at the Black Women's Health Imperative, where she worked directly on maternal health advocacy for Black women. She also spent years on Capitol Hill as a legislative director, so she knows exactly how health policy gets made and where it stalls. Courtney is also a Florida State alum, an aspiring chef, and a mom to an energetic preschooler, which means this conversation isn't just professional for her, it's personal. We're going to talk about what's really happening to Black mothers in this country, why heart disease is killing them at rates we should find unacceptable, and what we can do from the exam room to the halls of Congress to change it. Before we begin, if you believe that every mother deserves to thrive, not just survive, please take a moment to like, subscribe, or follow Prescribing a Healthier Future on whatever platform you're using. It helps us reach more families who need these conversations. So let's talk about what's really happening to Black mothers in this country. Good morning, Courtney. Thank you so much for being with me today. So I've already given the listeners your bio, but really want to know your story. How did you get into this field? Tell me about your journey.
Sure. Thank you so much for having me. It's great to be back in San Diego with you. I know we've participated with you in a couple of your community outreach events, and it's always great to see the participation and really the engagement from your constituents and really from you.
Thank you.
Your leadership is really inspiring. How did I get here? It's a little bit of a long, windy story. I started out, grew up in Florida. My mom worked for the Florida legislature, for the Florida Senate. And so I always joke, like, from a little kid, I was like maybe the only kindergartner who understood that there were 3 branches of government and how they worked and how advocacy worked, and watching all of that kind of sausage making come together up close. And so I'm just really grounded in that. Went to college, was a music major, trying to get away from it, but came back to it, getting a master's in public administration. And after I finished, I was like, well, what do I do with this thing? A bunch of my colleagues were going to D.C., to Capitol Hill, and I said, well, I think I'm going to try that too. And I ended up working for a senator from my home state, Bill Nelson, and that kind of really whetted my appetite for policy on a federal on a federal level. I'd seen it at state level, but on a federal level, the depth and breadth is a little bit wider. And starting out in the U.S. Senate, the Senate is a creature all of its own, and watching how, the sausage gets made there. But I started out as an LC, so you may not know that's the legislative correspondent. So that's the person answering your mail and answering the questions. And so health policy questions were always part of that.
Okay.
Moved over to the House and worked for Eleanor Holmes Norton and worked on her healthcare portfolio, and then worked for another member from my home state, Kathy Castor, as her legislative director. And interestingly enough, about a year into it, we started working on the ACA. Now, I say all that to wind up to this was a very pivotal moment in my career. We were working on the ACA. She was a member on the Committee of Jurisdiction, Energy, and Commerce. But that year, my father was placed in the heart transplant list. And 2 months later, my mother was diagnosed with non-Hodgkin's lymphoma in her brain.
Oh, wow.
So, very critical moment where I am working on the most impactful healthcare policy of generations, but I'm also living this healthcare reality of being an only child, taking care of 2 parents in 2 different states. And so it really drove home to me. You start thinking about some of this stuff, when you're a staffer from a esoteric level, but a personal level. I'm sitting in a waiting room in Tallahassee, seeing people that I know. We're talking about health equity. They don't know they're talking about it, but they're talking about social determinants of health. My children have to bring me to my appointment. I'm not sure if I'm going to pay for my medicine or my rent, or I'm not sure if I'm going to pay for this procedure or my phone bill. And so that really kind of dug into my purpose on health equity, and has really been that thread that pulled through while I was at Black Women's Health Imperative, and even my work at Pharma. It's become a great deal of that.
So when you're looking at the healthcare landscape, and you dug in ACA, and that really was about healthcare and affordability and access for everyone. How did you hone in on women's health? I know you're a mom, but what drove you to really focus in on women's health, specifically even Black women's health?
What really focused me and what really drove me to go to Black Women's Health Imperative is that when I was on the Hill, I never saw anyone come in and talk about specifically Black women's health. It was advocacy around, a chronic disease or cancer, or can we get funding for this thing or that thing. I never saw anything that said Black women are at the forefront of what we are doing. And so I said, well, I really want to be a part of that. And some of it was watching, my mother's journey through her cancer care, and thinking about access and affordability. One really big issue that happened when my mother was having her care and we're in the middle of doing ACA is I just happened to meet with the hospital association head one day. And I said, I'm not comfortable with the level of care that she's getting at this hospital. Do you know the president of the hospital? Did you happen to know him? 30 minutes later, the president of the hospital was calling me at my desk on Capitol Hill. And so I'm thinking about access. I'm thinking about this is what it took to get my mother access. I had to use that privilege, that access point, to try to affect change on what her treatment plan was. How many other women, not a bunch of other women, have that type of access, can reach out and say, do you know this person? Do you know that person? And so it really caused me to want to be an advocate for women, to speak up, to teach them how to ask the right questions, how to advocate on behalf of themselves, to think about how policy works. I hear a lot of people say now, I don't do politics, but politics does you.
Exactly.
And so that really kind of sparked my interest in, what's happening around women's health how can I be helpful? Where are the ways I can make impact?
You know, when we are thinking about women's health, and that is something that is very near and dear to my heart, people say, how long have you been doing this? Well, I am an OB-GYN as well. So for a very long time, and decided to go into women's health and train at some of the hospitals and work at some of the hospitals where you had the most need. Cook County Hospital in Chicago is where I did my residency, and then I was on faculty at Parkland, which is a community hospital, large community hospital in Dallas, Texas. But when we look at the mortality rates, the death rates for Black women in pregnancy or in their postpartum period, it is staggering.
It is.
And I don't think that, especially a few years ago, we've been talking about it a lot more now, I don't think that people really understood how dangerous pregnancy can be. It is definitely a blessing. You're a mom, I'm a mom, but it is a state in which your body is really, really pushed to the limit. And when you come into pregnancy already weathered from all of the social determinants of health, microaggression, racism, and things like that, then it has a much more jarring impact. And it doesn't matter how much money you make, and we've seen that. You could, have very little, or you can be a multimillionaire, and your complications and your chances of coming out unscathed are much less than your white counterparts, your Asian counterparts. And so Black women have a mortality rate that's around 3.5 times higher than white women. And even within the United States, even with all of the resources that we have, a leading developing nation, we have one of the highest mortality rates overall for all women. But specifically for Black women, cardiovascular disease or heart disease is the leading cause. When we're having these conversations, it's really hard for people to wrap their heads around the notion that a country that has so much money, so much resources, some of the best universities and hospitals in the world could have these numbers. Why do you think that is the case?
Well, I just told you a little bit ago that I'm in a PhD program, and we are really delving into, shout out to Mary School of Global Health. One of the things that we have kind of started out our curriculum with, and, there are things that we know, but when you really start looking into it, it's just the history of legalized segregation, redlining, how hospitals were formed in the United States. And so you start really understanding there's a long systemic structural impact that affects how communities have been formed, that affects how healthcare access is able to be given to residents. And so it's a continuum that we haven't figured out a way to disrupt that continuum. We haven't figured out a way to disrupt that continuum of how do we provide greater resources in under-resourced areas, how do we engage communities to tell us what their solutions are instead of just assuming we know what their solutions are. But you raise an excellent point about maternal mortality. I mean, Beyoncé had an issue with her births, with her twins. Serena Williams almost died, it seems, from a blood clot. And so to your point, it doesn't matter whether, you've won a Grammy, you won a Grand Slam, or whether you're just a everyday Black woman just getting up, doing your work, making sure your kids get off to school, making sure things are running in the home, because we are the people that keep the engines going at home. It doesn't matter. I know from my own personal experience, I was 39 when I had my son, so I was 2 months shy of turning 40 when I had him. So I was a geriatric pregnancy, and I had a lot of thoughts about that.
Nomenclature. Geriatric, you say advanced fraternal.
Well, 10 years ago, they said, you're a geriatric pregnancy. And I said, okay. But I was very intentional because I knew I had the know-how to say I want a Black OB-GYN from the beginning. I was intentional when my child is born, my son is born, I want to make sure that I have a Black pediatrician so that I know that I'm getting the best care and he's getting the best care. So because I was geriatric at the time, I'm making sure I'm exercising, I'm eating the fruit, I'm trying to stay away from the bad things. But month 7, blood pressure started going up. And then it was like, oh, you might have gestational diabetes. And I went and took the test, and the lab messed up the results of the test. So I had to go take it again. So 2 weeks before I had my son prematurely, preterm birth, then I found out, oh, you really do have gestational diabetes. You need to be pricking your finger. You need to be checking your levels. And so to your point, it doesn't matter. You can do all the things right and still lead to that outcome. And so I remember I went to that 8-month appointment, and the doctor, my OB-GYN, Dr. Joanne Jackson, she said, be at Sibley in an hour and a half. You're not having this baby in December. It might be the end of November, but you're going to the hospital today. And went on a Wednesday and had him the next day because my blood pressure just kept going up and down. It wouldn't stabilize. And even after I had him, my blood pressure was still up. And so a lot of people don't talk about that. Even, you have this beautiful baby and you see the pictures of the mom in the hospital, and then something happens. You take a turn. We know that about 60% of Black women over the age of 20 have some sort of cardiovascular issue even before they go into pregnancy. 20 and up, you're talking about cardiovascular issues. And so those things carry on through the pregnancy and after the pregnancy, which leads to some of these complications that we see. And I don't know if you are on social media. I scroll and a lot, but did you see the video a couple of weeks ago, the Black woman in Texas? I cried every time it came on my timeline. I almost was like, I need to mute this. And then I said to myself, I can't mute it.
Right.
Nobody else can mute this. The women that are going through this can't mute this. Black maternal health experts can't mute this. We have to be listening to this at all times to be able to tell the stories and to be able to say, this is why healthcare is so important. Access to healthcare is so important. Early screening is so important. Access to diagnostic testing is so important ahead of pregnancy. In that period where, before you're thinking about a baby, what do I need to do to be healthy? The period while you're pregnant and the period after you're pregnant, which is so tender. You're trying to keep a newborn alive, yourself alive. You're trying to get through those sleep-deprived moments, but then you're also trying to maintain your health.
Right.
And that's a lot to manage.
It is. It is really a lot to manage. And, it's a very complicated system. There are so many historical and current factors that have brought us to where we are today when we talk about overall maternal health, but also specifically Black maternal health. You talked about the fact that you were very intentional about finding a Black OB-GYN. Unfortunately, in many parts of the country, even here in San Diego, people don't necessarily have that opportunity. I remember when I had first gotten elected to the assembly, I was torn about going because at that time there were probably maybe about 5 Black OB-GYNs here in San Diego, and I was one of them. And I was the only one at the time at UCSD, and I think they had, 1 or 2 at Kaiser and maybe 1 at Sharp. But your options were very limited, and we're talking about like 4 years ago.
What does that look like now?
It's a little better. I think it's maybe less than 10, but it's more than 4 or 5.
Okay.
And so, people oftentimes say access, they look at like rural areas or small communities and they say, oh, well, the access is limited there. But you can find that you have access issues even in major metropolitan cities, larger cities like here in San Diego.
I think those access issues are going to probably widen even more, right? There are already physician shortages and GME shortages, residency slot shortages. I'm from Florida originally, and my home state is facing a very steep cliff in physicians being able to practice. Like the general primary practice, general practice shortage is just insane. And I think that's something that's probably growing nationally. And how do we plug those gaps? Because those are very critical. You serve a very critical purpose, and other people in those slots serve very critical purposes for people to be able to access care.
Yeah, access has been an issue that I have been talking about ever since I got into the legislature 4 years ago, because, I've always said you can give everybody as much insurance as you want. And here in California, we were boasting about the fact that pretty much everyone had health care insurance, based on the fact that we had expanded it to pretty much everyone in the population. I said, that's nice, but if someone has insurance, but they still don't have access to a physician, to a clinic, to a hospital, we really haven't done anything but just giving them a card. And one of the things that we've seen here in California, and I know it's the same across the country, is a change in access to maternity care, full maternity care. So, across the country, 537 hospitals have just stopped maternity care over the last 12 years. And here in California, we have noticed it, and I have really focused. I actually had 2 bills these last 2 years trying to tackle that issue. The first one, Governor Newsom vetoed, and the second one, it was held in Assembly Appropriations, but they were all supported on a bipartisan basis because everyone understood our labor and delivery units are closing. Our residents that we are serving don't have access. There are places here in California where people have to drive 2 to 3 hours to the closest labor and delivery. And you would never think that, right? But that is the case here. And that is also the case across the country. And when we're seeing a lot of changes, especially to our Medicaid system, where you're going to have less and less providers taking that insurance because low reimbursement rates and some of the changes that are coming down with this current federal administration, you're going to have less providers that will see all patients with all types of insurance. And that is going to have a devastating impact on women, on women's health care, on babies, and their ability to just be able to go and deliver someplace safely and come home. I always used to tell my patients, what we want is healthy baby, healthy mommy, right? We can't necessarily say the route, maybe vaginal, maybe C-section, but what we want at the end of the day is for you and baby to go home and be safe. When you're talking about solutions for communities, a lot of communities have started, especially within the Black community, have started looking at doulas and midwives to improve their chances. Have you thought about that? Have you looked into that?
I think doulas and midwives are awesome. I kind of wish I had had one because I've heard so many friends have really great responses and outcomes. And I think they serve a very important purpose. In our community, we had basically doulas and midwives. When we couldn't go to the hospital, when we couldn't access public spaces, public hospitals, we had doulas and midwives in our communities who were the people that helped birth generations and birth the babies in the communities. And one thing that I think that doulas are really great at is understanding their patient on a personal level.
Right.
What are you afraid of? What are your biggest fears? What is your hope? How do you want to have your room when you're having your baby? Do you want to have music? Do you want to have 2 or 3 people in there that are reading your favorite poetry? How do we create an atmosphere that uplifts the mom in this very tender point in her life? But also, I think doulas and midwives have a very unique position. As a doctor, you all have very tight timelines and maybe not a lot of time to spend with patients because you just have to keep seeing folks, but they can go into the home and really spend some time. Are you taking your medicine? You got diagnosed with preeclampsia. Are you taking the medicine? Are you taking your aspirin in the morning? What are you eating? You have an appointment. Do you have a way to get to your appointment? And so I think that doulas and midwives provide a framework in a general uplift for expectant moms to try to take some of that anxiety away and try to help them have that healthy mom, healthy baby outcome at the end. And I know that California, I was reading the March of Dimes report cards on maternal health, and California has a B-, which is really doing above and beyond what other states are doing. But one of the things you all are doing is doing doula reimbursement. You all have expanded Medicaid. You've done the Medicaid extension for postpartum coverage. You have paid family leave. You have a state maternal mortality review board that is really taking a deep dive, looking to see where the issues are. And you and other legislators, I'm sure, are thinking about, well, from a policy perspective, how can we help support better outcomes? So I think it takes all of that, but I do think the doula reimbursement probably for you all has made a difference, because that preterm birth rate came down about 10% for you all. And I'm sure some of that is being able to access someone that can become closer to you. It can become closer to you in between those appointments when you're trying to get to the OB-GYN, and you have those maybe monthly, in my case, every 2 weeks appointments, but someone else who can come into your home, into your space, and help you feel comfortable.
Yeah. No, I think those, individuals like doulas are really important in the entire care, right? And to work with the doctor, and even, with a midwife to work with providers, physicians, because we always want that easy delivery, but when something goes wrong, we know that we need physicians, and we need for that team to work in a coordinated fashion. Absolutely. So that at the end of the day, you have the best outcome for the mom and for the baby. I want to switch gears a little bit and talk about along the lines of access, but dealing with insurance, especially since you worked a lot on the ACA. We're having some significant challenges with healthcare coverage here in this country. We are seeing a rollback of the ability for people to be able to access care. You were there at a time when it was being built up to expand access, and now we're seeing a significant rollback in that with this current administration. How do you see this impacting the health of women, and specifically Black women, the way in which this federal government is currently going?
Oh, my goodness. From a purely Courtney perspective?
Yes, just from Courtney.
It's devastating. How many people are going to lose coverage? How many more people got coverage under the ACA, under those subsidies, under Medicaid expansion? How many people have lost coverage now once the public health emergency was lifted after COVID? So you've already got people who lost coverage that got expanded under that public health emergency under COVID. And now you're talking about we're going to be even more restrictive. So many people are going to be impacted. And, what's the old saying, when white America gets a cold, Black America gets pneumonia, right? We're going to come up sicker. And that's problematic for many reasons, because right now we see the statistics that we disproportionately are impacted by, all the things, all the chronic diseases, you name it, we have it in higher rates. And a lot of that is due to the fact that we don't get diagnosed sooner, we don't get screened sooner. So by the time something is caught, it's way later in progression, and you're talking about very sometimes advanced treatment. And so when you're talking about taking people's insurance coverage away, how are they supposed to maintain their health? What is the recourse? But also, I think we do a very poor job of teaching people how to use their insurance right now. I read somewhere recently, like the health literacy rate in the United States is, less than the 6th grade level. People don't know what a deductible is. People don't understand what a copayment is. People don't understand step therapy or utilization management. A few years ago, we had a conversation with a group of state legislators and an executive director of a third-party group, and we were explaining some of these concepts. And they were like, oh, is that why the doctor told my mom she has to try this drug before this drug? Oh, there's a name for it. And so I think even when you have insurance, there's a question of how do you use it effectively. But then once you get it, whether it's Medicaid expansion or the subsidies or even employer-sponsored insurance, when you lose it, then, what do you do?
Yeah.
And I think this is especially impactful right now. I think there's an article out now that says that like 400,000 Black women have lost their job since the beginning of the year.
And that's no insurance.
That's no insurance. That's, losing your employer-based insurance. COBRA costs a lot of money. If you have the option to keep COBRA, you're paying a full out of pocket on everything on COBRA. So if you've lost your job, how then can you pay for COBRA? And so a lot of people are now going to be like winging it. Hope and a prayer. I stay well, my family stays well. What can I do to keep us well? Which also adds to that weathering, that stress, because that's an added stressor on top of all the other stressors that you already have. And so, from a purely Courtney perspective, we've got to do a better job at policy making and having real people go, whether it's to the Hill on Capitol Hill or here in California, and telling their stories, being very upfront about their stories with their legislators, with the people that are making the policy, and say, hey, this is what your policy is doing to my life. This is, I was watching a podcast the other day, and an older couple, and the man said, well, I was thinking about retiring, but my wife is in the exchange and just her insurance is going to go up $2,000. So I think I'm going to keep working for a few more years. It has real life impact.
Yeah. It's interesting, and I say this a lot here in California as well, but healthcare is extremely expensive. But the way to decrease the cost of healthcare is not to take it away from people. Is to actually ensure that they have it and that they're educated about it, and they go and they get that preventative care. Because it's a whole lot less expensive to prevent someone from getting hypertension, diabetes, obesity, whatever, than to treat it. Because at that point, it is a chronic condition. It is a lifelong thing that will have other consequences as well. And for whatever reason, it's very difficult for people to make that connection, that if you prevent something, yes, you may spend a little bit more money up front, but you will save so much more money in the end. And overall, the healthcare system will be less expensive. I want to jump back to advocacy. How do you think that patients, communities can advocate for themselves a little bit better?
Telling their stories. And so I've seen all the things and all the ways in which advocacy plays itself out, whether people do, whether it's direct advocacy, there's a lobbyist that's behind a group that is advocating for a certain point of view, a certain policy, whether it's more grassroots related, that's coming up from the community. But what I've always seen work is when community comes together and they agree on the goals. This is what our issue is. We want more doctors in our area. We'd like to see more doulas in our community. What do we need to do that? Who are identifying the people with the resources to do that? Who appropriates the money? Who can authorize the program at the state level to say this is a doula program, we're going to authorize it, then we're going to go to appropriations and get the appropriators to fund the money? Who, when you see the data come up from the communities, like these are what the impacts are in our communities. These are the babies that are having issues. These are the moms that are having issues. These are the personal stories. And out of these personal stories, this is the type of policy action that needs to happen. When you see that sort of groundswell come up from the community, and when you're persistent about it. One thing I would tell folks when I was in my LC days as a legislative correspondent, at the end of the week, we had to give metrics on what are the letters that we got the most mail on, what did we answer the most mail on. And the senator looked at those. And it's the same way in the House, members of Congress. When constituents are loud about a certain issue, if they're looking at a report and they're saying, I got 2,000 letters on doula reimbursement, I got 2,000 letters on chronic diabetes prevention and funding that program, then they're saying, what's going on here? Clearly, there is something here that my constituents are asking for. What more do I need to do? And I think a lot of people don't understand, too, the power of staff. I know you have a great staff behind you, but getting to know the staff in a member's office, being present all the time, sending regular communication, not in an annoying way, but in a very educational way. Here's where we are on this issue. Here's what the state of play that we see. Here's what we'd like to see from our member. That type of round, sustained, persistent, on message communication, I think, goes a long way in terms of being effective at advocacy.
Yeah, no, thank you for that. And I know you've been behind the scenes to actually know what works. A lot of times people don't realize that when you reach out to your elected official, whether it be on local or state or federal level, there is someone that's actually reading those emails, that's listening to that phone call, that's taking notes, that's reading your letters. There really is someone on the other end. And so it doesn't just disappear into the ethos.
I think people think it just goes into the void. No, it does not. There are people who are taking stock, trying to figure out what the messages are. Oh, this is important. We need to do a little bit more digging about it, find out what's happening in the district, find out what we can do, what remedies there are that we can be helpful in pushing. And so, it doesn't just go into the void. And I think a lot of people are frustrated with the political process right now because they say, oh, we don't see immediate effects. Well, that's not how politics works.
Especially not in Washington.
Especially not in Washington. But really, I think at any level, it's an everyday continuous conversation and push. Sometimes it takes a year, sometimes it takes 10, sometimes it takes 20. But it takes very sustained, determined sort of advocacy to make things happen.
And, someone had asked me a while ago, it was on some panel that I was on, kind of dealing around advocacy and utilizing your voice. And I was saying, don't stop, just kind of like what you said, be persistent. Because the person who doesn't want what you need is also being persistent.
Yes.
And at the end of the day, when they get to that issue, who's going to be the voice that's still there?
Correct.
Is it going to be yours?
Or is it going to be your opposition?
Or is it going to be your opposition? And so you're right. People get like, oh, I'm so tired, or I'm not interested, or things don't move quick enough. We're this microwave generation with microwave
instant gratification.
Instant gratification.
Yes.
So we're just done. We're done with the process.
Can't chat GPT it.
Can't chat GPT.
It takes a long time.
But on the other side, the person who doesn't want what you need, what your community needs, is being persistent.
It's being persistent.
I look at
and maybe more well funded than you, and getting farther. And so you have to think about, well, what do I need to do to step it up to the next level to combat that?
Exactly. And so I think of the issue of reproductive women's rights as a great example. So we got Roe v. Wade passed years ago. There were people who were against it, and they continued to be persistent.
Yes.
And so now, generations later, we're seeing that rolling back because those voices in opposition, they continued to be very vocal and very persistent, and they just stayed the course.
They stayed the course, and they played a long game. When I was at the Black Women's Health Imperative, I was working on some of these issues, and we were part of amicus briefs about Roe and Hyde Amendment and all that type of thing. And I think what unnerved me so much with the outcome of what has now happened with Roe is exactly what you said. Just it was always there. It's a very persistent drip, 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 and that continuous drip got them to get that rolled back. And so I think that is the sort of doggedness that people on both sides of the issue, but if you're really trying to affect change, you have to play the long game. You have to think about who's running in the next election. How do you get in front of that person? How do you get your issues in front of that person? What are they interested in? Are they interested even in the same things that you're interested in? Is there someone that you would like to see be part of politics that you know has been effective in the community level that you think would be effective at a state legislative level or whatever, in whatever capacity? How do you help support that person? And I think that that's what the other side has done an excellent job of doing, is they have done a very good job of filling their pipeline in a way that perhaps the other side has not.
Right.
And so how do you do that? It's a very strategic, I don't want to say game, but it's a very strategic way of thinking and being. And, you know, a lot of these issues that we're talking about right now are very heart issues, emotional feel issues. But sometimes you have to take the emotional out of it and think from a strategic standpoint of how am I going to get this done?
Yeah, exactly. And I also want people to realize that advocacy is needed on a, you know, on the political realm, local, state, and federal, but also within your own lives and within your own communities. And so we need more advocacy within our schools for our children. We need more advocacy within, you know, the hospitals and the doctors and the clinics for our health, your individual health, your family's health. You talked about the fact that you were advocate for your parents. And even with all of the education and connections that you had, you still had to push and push. You know, it was interesting because a couple of months ago, a family member, she had a mass in her pelvis. And she had a history of a very benign type of cancer. Not benign, but like very low grade. And it was so low, she didn't need any follow-up. So now a couple years later, she's got this large mass in her pelvis. And she goes to see her gynecology oncologist, and I'm on the phone. So I'm a board certified OB-GYN, and I'm a California state senator, right? So I'm on the phone.
Lots of big guns.
And big guns, right? But it's family. So I'm listening in, and the gynecologist says, I think she needs chemotherapy. And I was shocked. I said, but do you know what it is? Well, I just assume it's probably just like, you know, the old tumor coming back and da-da-da-da-da. And I said, well, she had very low grade, like so low grade she didn't need like serial imaging or imaging after to make sure. Yeah, I know, but it's kind of in the same area. And I said, well, God, you know, I'm not a cancer specialist. I am a gynecologist. And this just doesn't add up. Like, why would you recommend? He was like, well, I think, you know, because of the size, we'll do maybe like 9 rounds of chemo and then, you know, go in for surgery to remove it and da-da-da-da-da. And I was just really befuddled that this was the recommendation of this provider. And, you know, I'm on the phone. You know, I've got some medical history. So it was really kind of weighing on my soul. And so I said, you know what? This is not what we need to do. I called later. I said, this isn't what we need to do. We need to do a biopsy. We need to know what this is. And so, you know, my family member was like, I trust you. We'll do the biopsy. Biopsy came back benign muscle tissue.
And she was prescribing chemotherapy.
That was what he wanted her to have. Benign muscle tissue.
Wow. So possibly poison.
Oh, yeah.
Medicine, you know.
I mean, chemotherapy
is needed, but it's toxic.
Yeah.
I mean,
yeah.
I remember from my mother's experience, you know, chemotherapy is nothing to but I think what you're talking about is like implicit bias, right? In the system, in medicine.
And even
in healthcare.
Even so much when you have someone who is just as educated as you.
Yes.
Who knows medicine, who knows has different connections. This is still your recommendation. And that's why it's really important for people to understand their own power. And yes, you may not feel comfortable being an advocate, you know, going to Sacramento or your state's capital or the Washington, D.C., but there's a lot that you can do within your own life, within your own family, within your own community, just by using your voice, using whatever resources you have, using the internet. People use Dr. Google and ChatGPT all the time to really look into things and question things if it doesn't feel right within you.
I think, though, there's a fancy term for that. It's called epistemic justice, and it's recognizing patients as knowers of what's going on with them, understanding their stories and saying, you know what, you've lived in your body for however many years you lived in your body. You know when you know something is off. And I trust you when you're coming into me to tell me your story to say, I should probably order this test or that test, knowing a person's, medical history as well. But I think, that's another issue with Black women in particular, when we go to the doctor and the doctor's like, I know, what you're describing, I don't think it rises to the level of seriousness, or prescribe something else that ends up being, not what is needed. And so I think it's very incumbent upon us, to your point, to kind of speak up for ourselves, to say, no, I know what I'm saying. I know what I'm feeling. I know that something isn't right. This is not the norm for me. And if you can't give me what I need, I'll go get a second opinion. I think sometimes people get wedded to, who they've been going to for a long time. And sometimes they may be afraid to go get a second opinion. But I think a second opinion is always needed. When you feel like, this is off and I'm not feeling the diagnosis you're giving me, the recommendation, I'm not feeling the whole situation, then you need to go to get a second opinion and feel empowered enough for yourself to say, I'm going to do this for myself.
Yeah, definitely. Well, I want to thank you so much. I have really enjoyed this conversation. I appreciate you coming on. I appreciate all that you are doing for Black women's health throughout the nation with your current role at Pharma. We really need more people like you at the table in all aspects that deal with society, not just healthcare. But I'm so happy that you are where you are. I appreciate you. I love our conversations, and look forward to seeing what you do. You're about to do some big things.
We'll see what happens. Thank you so much for having me. Thank you so much for the work that you're doing. It's vitally important from the space that you sit in as a Black woman, as an OB-GYN, state legislator. It's vitally important what you're doing and the voice that you're bringing to the state legislature. So thank you so much for what you do as well.
Well, thank you. This conversation matters because the women we're talking about matter. To our listeners, if you're pregnant, if you're planning to become pregnant, if you love someone who is, remember what we've talked about today. Build your support team. Don't let anyone dismiss what your body is telling you. And be your best advocate. If you found this episode valuable, please share it. Share it with pregnant women in your life. Share it with her partner. Share it with anyone who needs to understand why this crisis demands our attention. I'm Dr. Akilah Weber Pearson, and this has been Prescribing a Healthier Future. Until next time, take care of yourself and each other. And be well.